everyone. Welcome to the American College of Healthcare Architects Master Series 2.0. We'll be bringing experts from our certificate base to weigh in on the healthcare issues that matter most to you. My name is Angela Mazzi, 2021 president and partner at GBBN Architects in Cincinnati, Ohio. Joining me is my co-host, Steve Tomplay.
Thanks, Angela. I'm Steve Tomplay from New Orleans. I am an associate with Seisler Architects and a healthcare design architect.
Joining us today is Ann Adams, principal at Davis Partnership. Ann is responsible for programming, master planning, design, and construction of projects from small critical access hospitals to large multi-million-dollar facilities. She has 35 years of experience in the industry, completing renovations, additions, and replacement facilities for projects around the country. And her strength is managing the communications and organization of these complex projects. Prior to joining Davis Partnership, Ann practiced architecture in many environments. She was an owner's rep for a national program management firm. She was an associate vice president at a national architecture firm and the in-house director of architecture at Memorial Hospital in Colorado Springs, Colorado. Also joining us today is Rebecca Lewis, principal architect and director of healthcare design at DSGW Architects in Duluth, Minnesota. Rebecca is recognized for her peers as a national expert in healthcare architecture, gerontology, codes and standards, and guidelines for the healthcare architectural community. Her depth of knowledge in the field of healing communities is motivated by her pursuit to create environments that reflect these ideas and ideals. On a national level, Rebecca plays a leadership role in speaking throughout the country to professionals about new architectural approaches that improve the experience of patients and staff. She's a fellow of both the AIA and the ACHA and has been a long-serving member of the Facility Guidelines Institute Health Guidelines Committee and the 2022 Steering Committee, as well as the FGI Emergency Conditions Committee. Her experiences working with small rural hospitals and healthcare providers has made her a much-needed voice in the national arena. Joining us today from HOK's Atlanta office is Karen Freeman, who leads the healthcare practice. She has focused the vast majority of her 23-year career on the design of facilities for children's health. Karen understands that pediatric healthcare is far more than scaled-down versions of healthcare for adults. It requires responses that leverage technology, support the physiological, emotional, and all-over needs of pediatric patients and their families, and both engage and delight children of all ages. Karen has earned her EDAC accreditation, holds a Lean Six Sigma Black Belt in healthcare, and is a member of the American College of Healthcare Architects. Thank you for joining us, all of you.
The first thing we wanted to ask all of you is what comprehensive care really means. So, Anne, when you think about this, how are you seeing ambulatory projects shift toward that comprehensive model? And how would you distinguish it from ambulatory care?
Well, I think the first, it's really taking a holistic approach about a person's health, when that's not just physical, but mental, comprehensive, cognitive. And I think where we're starting to see that shift happen is really more in trying to get everything all under one roof, right? So you have all those disciplines in the same facility. Interestingly enough, out in my part of the world, I'm in Denver, Colorado, and there are some of those out there. There's not a lot of them in this region. I think more the system clients are really starting to see that. So we're in that process of making that shift right now.
Mm-hmm. And Karen, what are you seeing in the world of pediatrics when it comes to comprehensive care?
So I think the shift to comprehensive care has been happening for quite a long time in pediatrics, and it's by nature of peds, subspecialty care, children with complex conditions. Those specialists often exist only in major cities, major hubs across the United States. And so the idea of parents who are dealing with children with complex conditions, coordinating schedules for multiple providers across appointments when you could be driving 2, 4, 6 hours to these specialists the opportunity for a health system to aggregate these services into a single place for the benefit of the patient and the family, and to be able to provide a comprehensive spectrum of patient care for that child is incredibly important. And we're seeing more and more of our healthcare systems developing these kind of outpatient facilities that do co-locate all these subspecialties together. And that's kind of augmenting what I would typically think of as ambulatory care, which is more the primary care physicians and pediatricians, and supplementing that with expertise and knowledge that goes beyond those primary services.
Rebecca, with your background in rural healthcare design, how does your definition of comprehensive care possibly differ from everyone else's?
Thanks for asking for this perspective on this panel. It's always nice to be asked about rural healthcare. I would like to share, I think my favorite definition to start with of comprehensive care is from the American Association of Family Physicians. And it says, it's defined like this: the practice of continuing comprehensive care is the concurrent prevention and management of multiple physical and emotional health problems of a patient over a period of time in relationship to family, life events, and environment. So it's everything that Anne was saying when she started talking about comprehensive care and the ambulatory models, but it's on a few other things that I feel strongly about ought to be included in comprehensive care. But before I get to those things, let me just say that in my experience, ambulatory care is just part of comprehensive care. The comprehensive care is a delivery model. It is the approach to care. Ambulatory care is just the patient type. So you can have comprehensive care in inpatient settings as well as outpatient settings. But I think outpatient is maybe taking a little bit longer to catch up, which I think is the reason why we're talking today. Now, the 5 things that I think should be included in any kind of comprehensive care design or philosophy when you're meeting with the client and talking with them is it should include, of course, medical interventions. Obviously, that's what we're there for. The integration of behavioral health, just like Anne mentioned earlier on. But I think it ought to include community awareness. So thinking back to that definition where I talked about environment, it should also include cultural sensitivity and spiritual well-being. So I think with those 5 things, you're starting to really get at the heart of what comprehensive care really means. For the rural provider, I think what's different is in our very small communities, the rural provider is oftentimes sort of the only one. So that provider is acting as an advisor in all of those areas. They know the family, they live next door, they shop at the same hardware store, they go to the same coffee shop. They're aware of family situations, they know the children, they know the relatives. So they have a different perspective when it comes to sort of naturally being that resource. I think where it starts to change is when you start getting into medium-sized hospitals, and that to me would be more like a 50 or 60, 70 bed hospital and up, where you start to see the breakdown of some of that individual provider overall comprehensive care, and you start looking at the silos that create barriers to creating that comprehensive care. I do want to point out, though, at least one other thing that's really important about comprehensive care, and that has to do with the guidelines. As Angela mentioned, that's something that I've been involved with for a long time on behalf of AIA. And Chapter 1.2, the environment of care, talks about important items that need to be discussed at the beginning of a project. And it does talk about a lot of these kinds of things, and it specifically talks about cultural responsiveness. So I want to make sure that we understand that that is a very, very important element of comprehensive care and needs to be part of the recipe for success for a project.
I think the other piece too is worrying about the families that come here. So especially in rural facilities, if they're going to be someplace, if they're going to go to a place where they're going to get all their care in under one roof, how are you providing for the families that might be waiting for their significant other to get their care, and how can they pass their time as well?
Those are both great points. And as we find ourselves both as designers and patients or family of patients in today's environment, it's just even more critical to understand those ideas. So that takes us to our next question, and I'm going to start with you first this time, Ann. There's been a lot of change in the healthcare landscape recently, for obvious reasons. What changes have you seen where technology is concerned, and specifically telehealth, in the ambulatory care environment? And can you take us through possibly your unique experiences on both the owner and designer side?
The past 18 months has really kind of put a significant burden on IT, on technology in general. And I think some of the things that are coming through where, you know, when you first started, it's like, call me when you get there and, you know, we'll let you in, and, or come in the back door because we're not sure if you have COVID or not. And some of our clients have developed apps now that you know, it's kind of like, you know, that they can, I'm here, and they'll say, okay, wait in your car. And then, you know, you're 5 minutes from your appointment. And I think I was chatting with one of my clients today, and they even said, yeah, that they think that's there to stay. The waiting rooms are going to get smaller. And we debated about whether the parking lots are going to change. You know, do we need more parking or not? And she doesn't believe so. And I'm like, oh, I don't know about that. But I think that, you know, that some of these transitions are here to stay. You know, they're adding isolation rooms into their ambulatory care settings that they didn't necessarily before. One or two, they're going to start having a back of the door access that's really planned appropriately, so that those isolation rooms are right by their back door. Air changes are going to change to some degree. So I'm sure others have things they can weigh in on as well.
A really interesting point, Ann. And we've had recent conversations with some of our clients about augmenting and boosting their Wi-Fi signal in external parking lots, so they have a reliable data and signal as they're waiting, instead of just relying upon data, which can not always be as consistent as necessary.
Also have to worry about the elderly too. And I just spent a week with my parents, and you know, they like to think that they're up on technology, and they're not. You know, a Zoom call just about stressed my mother out. And so, you know, just trying to understand, not everybody knows how to use their phone, and you need to have old technology as well.
Those are great points, Ann. And for the other end of the spectrum, I'm going to ask Karen to weigh in on technology and how telehealth has affected the pediatric side of healthcare design and healthcare environments.
Pediatrics, outside of the primary care environment and really in the specialty environment, we're dealing with children with more and more complex conditions, and treating those patients remotely is more and more difficult. But the benefits, I think, to telemedicine in the pediatric environment that a lot of our health systems have realized over the last 18 months. And I'll step back and say that one of the real barriers to that in the past has been reimbursement. And the pandemic has accelerated, you know, the need to sort of work out reimbursement for telemedicine. And I'm hopeful that a lot of the processes and procedures around that from the insurance perspective are here to stay, because I do think it's a massive benefit to our patients and their families. But the benefit is, as I was saying previously, with this long distance to some of these specialists, the ability to, for a primary care physician to consult remotely with a specialist in another town, for a specialist to monitor a patient's condition and their stats and their vitals and whatnot over a long distance, and not have them come into the office, not potentially put themselves at risk now that we know how severely this particular pandemic is also affecting children, I think is just a benefit all around. And the more we can leverage that, the better. I do think about opportunities for health equity. And I know that's a question that we're going to address a little bit later on, but as we transition to more and more technology and more apps, how does this marginalize and further affect some of the patients who are having access issues for health equity in the first place? And we've talked about, you know, expanding parking lots. What about our patients who don't come in their own vehicle? Maybe they ride share or arrive by bus. What opportunities do we have for them to ensure that they have an excellent patient experience from their arrival on the campus, wherever that may be, to the time when they ultimately see the doctor? And for those patients who don't have as much access to technology at home, how do we boost that as a community, as a response to our collective community, to ensure access is continuing throughout the spectrum.
Thanks for sharing those important points, Karen. And I think it's critical to remember how those small details can really affect the experience of our healthcare environments. And I'm going to ask Rebecca to share what maybe some parallel thoughts on her experiences with technology in the rural landscape.
Telehealth is a great option for a lot of things, but in the rural communities, to try to deploy that without a broadband background is just, it's the end. So for those that I've had a chance to speak with in different kinds of presentations, I've talked about this for a long time. If you look at a map of the US and the broadband coverage today, there's a lot of areas that don't have anything, and they're mostly rural. So, all of the 5G and the everything that a lot of folks enjoy in their urban settings are not available to our friends in the rural areas. So it really is sort of the end of the discussion if you don't have proper broadband or dependable broadband. I think the next big barrier to telehealth in the communities where I work is poverty. I think both Anne and Karen talked about this. Not everybody has a device. Not everybody knows how to use it. So, how do you make that happen? And I think one of the things that we're seeing deployed, if you want a good example of how we're trying to overcome some of those barriers, is to have small telehealth booths on I'll call it the public side of our rural clinics, where someone can make an appointment to come in and just use the booth. They can have a telehealth meeting with their counselor from far away or from some other group that might be helping them with their care. So we need to sometimes provide those things, and those things fit very well into the models that we all know of, the patient-centered medical home model and some of the new trauma-informed design issues that are really impacting rural health. I think the other parts that really work well with telehealth as a great barrier eliminator is obviously that they can be excellent for outreach. They can take care of some of that access. Karen talked about that. The travel distances can sometimes be hundreds of miles and can be over, some not very great roads. So those things can really allow patients to have access to specialty services and some of our team models of care that they wouldn't have otherwise. But there's just a couple negatives that get back to something that we talked about earlier with comprehensive care. And I think it kind of boils down to familiarity. Because folks don't have devices, because maybe broadband isn't their second language, it's not familiar to them. And they may not feel the connection with their doctor that they are used to feeling. They may not really feel like it's a real appointment. They may not be familiar enough to really sort of want to have that kind of a meeting or intervention with a provider, and therefore avoid it. So there's a little bit of that has to do with telehealth that I think we have to think about when it comes to cultural responsiveness and our clients.
I would add too, one of my clients, during COVID, obviously telehealth really increased, right? I mean, it just because of the nature of what was going on. But one of my system clients, a very large system client, said that their telehealth is going back down to pre-COVID level, maybe a little higher than pre-COVID, but I think people are expecting to see their doctor when they can. And I know I personally, if I had been on a telehealth appointment for one exam, they wouldn't have found something, and that, telehealth can't replace that, right? So I think the young 20-year-olds who are in pretty good health, that's okay with. And, maybe if you have a kid who's sick with strep or, that might be something easy to call in because, but I'm not sure it's here to stay. I think it's here to stay, but not to the degree that it has been.
I think you bring up a really good point there, Anne, because it is about patient engagement too. And it is about making sure the patient is connected, is following up with you, is keeping their clinicians appraised of any changes in their health. So have you seen any of your clients looking at that, health outcome issue in greater detail, and what are you seeing them do to try to impact lifestyle choices?
So I think one of the things that one of our, again, the same system client, what they're doing is they're starting to put in wellness into their facilities. So they actually have gyms and pools and daycare actually, so that they can, bring, they can bring your kids and you can work out and you can all under the same roof as what your clinic, where your clinics may be. Coffee shops in there too, again, talking about the family and how's that family going to be able to relax while your significant other's getting care. So I think they're trying to locate those around schools and in housing developments and places that will actually get used, not out in the periphery where a lot of times we find campuses. But they're trying to also get the MOBs off, or not the MOBs, the comprehensive care centers off of the hospital campus too, right? So get it where people will use it. And that's what we're seeing.
Yeah, interesting. And, this is a significant investment in amenities. So it's not just directly related to receiving care. So what's the payoff there? And I'll let you answer first, but then I'd also love to hear from Rebecca and Karen on that payoff in amenities.
Yeah, I think the payoff is that they're comfortable, right? They're comfortable going to that facility and know that, maybe I should make an appointment because my wrist doesn't feel right when I do, whatever. Or I think it's convenience, right? Nobody really likes to go and they get stressed out going to the doctor. But if everything is all under one roof where you go for just to go have a swim or just to relax, maybe that's the advantage.
Anything we can do to build that bond between patient, family, and provider, it ultimately will impact health outcomes in a positive way. I know that health systems are really looking, especially if they're maternal and fetal care, as an opportunity to sort of bring in new customers from the get-go and build a lifelong relationship with those patients as potential clients for them moving forward. So that opportunity to connect with a family at birth, moves into their pediatric care and ultimately, hopefully moves into their adult care if you've really built a relationship with a health system that you trust and providers that you feel like you have a connection to.
Yeah. So what things are you seeing that are really moving the needle on that, Karen?
So pediatrics, I think, is really lagging behind when it comes to, access and health equity. If you just do a quick search of publications over the last 5 years on the phrase health equity, it's increased about tenfold in that time frame. By comparison, the pediatric articles have only increased about 15%. So there's a huge gap there. It's not the discussion point on pediatrics that it really should be. I think part of it is defining what are those social determinants of health that we should be measuring our pediatric patients against, and how do we really identify where the inequities exist, and what the relationship to the community is there. What role do our educators play in that? What role do our community support systems, whether that's our Little League coaches and our piano teachers, and what role does the community at large play in the health of our children? And we certainly know that the health of children impacts everything later in life. It impacts adult health. It impacts their ability to learn. It ultimately impacts their economic success in our society. So it's incredibly important, and I don't think enough work is being done on this now.
Yeah, for sure. And I love that you talked about the importance of building community. So I want to shift things over to you, Rebecca, because I think in the rural environment, community has an elevated importance.
It does, Angela, and that's a great question. So when I was thinking about your word payback and what we're seeing when it comes to amenities, it's pretty different in a rural facility because of that community aspect. So think about it. If you built a brand new clinic and you included a coffee shop and some of the other things that we all appreciate as visitors, the town where this clinic might be may only have one coffee shop. And all of a sudden you've introduced a competitor that maybe hurts the business of some of the folks that would use the clinic. Same with the pharmacy, same with the, the local cafe. So what we try to do when we are, programming and thinking about projects in these small communities is a little bit of back and forth. And some of the more creative solutions we've had to sort of bring the community into the facility, even small ones, and then also bring the clinic back to the community, is to have something like you might have a coffee cart that is, controlled and run by the local coffee shop. So they bring up their coffee, they can serve it and sell it there at a cart that might be just in the lobby. You might have a community room where there's local groups that come together and have dances or gatherings, or the quilting club can meet. You might have another place within the facility that maybe has some vending machines, and maybe there's a place where the local pie shop can sell their pies. And at the same time, you might have trail maps available at the clinic. So someone waiting can go take a hike around the community or take advantage of what's happening in downtown. So there's a little bit of back and forth when it comes to kind of creating that community and supporting the community, as well as, making sure that the patient has, access, that understands where they are, that it's familiar to them, and that we're really respectful of those businesses that are already existing and maybe kind of struggling in those smaller towns.
I love that. It's not just coming in as we're the superhero health system, but that you are entering an ecosystem.
For the last few questions, I'm going to mostly challenge each of you to talk about what we see coming towards us in the future, both looking at it topically over the last few years and within each of our unique local experiences and environments. What would each of you think will be the single biggest disruptor in the comprehensive care landscape, both now and looking towards the future? And I'm going to challenge each of you to think of this in both positive and negative terms. Let's start with you, Anne.
I think reimbursement is definitely a challenge right now for a lot of the facilities, in terms, especially the telehealth aspect of it. I think the other thing is really it's cost, frankly. I mean, there isn't a lot of money out there right now. They're all trying to retrofit, figure out what's up right now. And I think what maybe a positive of it is everybody's thinking differently on how to use things. So for instance, I have a project that's close to being done right now. And it's like, oh, we're going to change how we're doing things. And it's, positive. It's making people think differently on how things have been done and how we can make changes going forward.
Thank you for those interesting ideas, Anne. Appreciate the depth of those comments. And I think we all understand that the last few years has forced us to review and challenge a lot of things within our experiences that maybe haven't worked so well. So looking toward the pediatric landscape, what would you think, Karen, will be the biggest disruption coming in your environment?
One of the disruptors globally across the healthcare spectrum, not just pediatrics, is retail healthcare and access and costs associated with that. And what does that do to our health systems and their opportunity to kind of integrate care across their system? I think there's been some wonderful things that have come from retail healthcare as far as equity and access to care. But how does that impact a larger and more comprehensive look at a patient's wellness journey? On the pediatric side in particular, I think one of the biggest hits that's happened over this pandemic is the need for mental health services in pediatrics. That's been growing for a number of years now. Mm-hmm. And I really worry that a lot of our kind of secondary catch resources for this in our school systems, in our after school programs, in those community services has really been hindered by remote learning. We're not seeing children outside of their home environment as much as we used to in this current pandemic, and that's an opportunity for a lot of these children to fall through the cracks who would otherwise been caught by some of these support services across the community. So I think that's a real challenge. We're seeing a lot of health systems close their inpatient mental health services, which is a really difficult thing to see when we know how much those are needed in pediatrics. So I'm hopeful that there are opportunities here that we can all learn from as we look at a more comprehensive care environment and ensuring that those mental health services are provided for patients across the spectrum, and what are the opportunities to do that from a remote perspective, and ultimately how could those be supportive of neurodivergent patients who may benefit from an environment that's a little bit different than the environment that we offer them now.
Thanks, Karen, for that unique outlook. I was just having a client conversation recently where we were talking about how behavioral health and wellness, specifically mental wellness, was becoming a priority for a lot of institutions right before the last 18 months happened. And then once again, it was put aside to focus on the crisis at hand. And yet we all realize just how critical behavioral health and mental health needs to be focused on right now.
Think of the stressors on our children, not having that routine that they've had for so long. That's so disruptive to their well-being. It can be disruptive to their sleep patterns, their ability to learn. Not to mention the fact that they don't have their teachers looking over them and starting to understand and see what their attitude and behavioral, how it might have changed over the course of this pandemic. But it's a lot of stress on families, and that really trickles down to pediatric patients as well. Kids pick up on so many of the stressors that we as adults are experiencing, and that can't go unnoticed by them. And what was previously skyrocketing, I think, has just gotten that much more difficult for everyone. So it's something I hope we do spend a lot of focus on and reshift our focus to after we start coming back together in person.
Well, that's really important, Karen. I agree with you completely. So Rebecca, in the rural settings, I'm sure some of the same disruptors have commonality with the more urban climates, but what unique disruptors do you see within your practice and clients?
In many rural communities for years and years and years, there's always been the clinic, and then there's the behavioral health or mental health clinic with a big summer might see you, and there's a stigma attached to all of this. So bringing these two things together is not as easy as it sounds. There's a lot of ideas about security. There's a lot of ideas about confidentiality. There are a lot of ideas about how these things ought to be separate, that you need to work with your clients closely with to encourage those things to be blended together on behalf of the patient. And you really have to design the facility completely differently so that when folks are in the waiting room or the waiting area, or however they're queuing, they go through a door and everyone in the waiting room knows where they're going. There isn't a special behavioral health sign above the door. There isn't any identification by who's calling that patient forward on what it is that they're going to be doing, because their neighbor might be sitting right next to them. And that familiarity of patient to patient really makes those kinds of things a lot more important. So I think, excuse me, there's a real clash, there's a real conflict when it comes to bringing those two together. And I find those discussions to be really rich, but very in depth when it comes to all the way from registration and how people enter, all the way through the patient care areas and how you can bring those things together. I think the other good thing that's happening that I suppose some people would think is a disruptor, but I think is super cool, and that is the just eruption of mobile units in rural settings that are doing things that we never thought ought to be done, but with a rural mobile unit. So, those are starting to create a different way of bringing healthcare right to your door or into your community where maybe access was very difficult. So personally, I think that's a really positive disruptor. I'd like to see more of that. And I think the behavioral health thing just takes leadership. And, a lot of us really believe that it needs to be knitted together with your primary care models so that they are seamless and discreet and elegant and, respectful, and really treat the whole person.
Thanks, Rebecca. And having grown up in a small town, I fully understand the stigma of behavioral health and how in ambulatory care, your neighbor could actually be your caregiver, which we can all understand the uncomfortableness of that at times, something that's not so common in large urban centers. Now, your thoughts on the positive disruptors for these new mobile health centers, literally on wheels. Do you see this within the idea of a push-pull dynamic? Are you thinking of this as a push from larger systems to provide care into smaller communities, or just the need pulling in help, no matter the source, from the small community?
I don't see it as the larger systems sort of using that as an outreach strategy. I see it more as a response. Obviously there's a lot of cancer care mobile units that we've seen. There are a lot of COVID, shot units that are traveling around taking care of folks. I think it's more of a response, but I also think that it's just incredibly convenient for patients that maybe don't have vehicles. I don't recall who mentioned that earlier. I think it was Karen when we were talking about equity. But many of these small communities, folks don't have cars. So imagine the difficulty of just traveling, 50 or 60 miles to get your health care. What if it came to you? I think it would be great. Obviously it has to be safe. There's no doubt about that. But it's a really important disruptor that could sort of take the old-fashioned house call and make it just a little bit different.
Wow,
This is great because I think, we've been hearing a lot of chatter in recent years about the shift to consumerism in healthcare and more ability to shop around or make choices, but we don't really see patients doing that a whole lot. We still see them sort of going the path of least resistance. And Karen, I wanted to direct this to you as kind of a look at larger trends and consumerism. Parents tend to want emergent care for their children when things pop up more often maybe than adults do. So how are you seeing some of the disruptors like online or the Amazoning of healthcare more than just the minute clinics making an impact?
Yeah, I think, these freestanding emergency departments that we're seeing pop up in the community. I'm working with a client whose goal is to never be more than 10 minutes from any one of their patients. And they serve a large portion of Central Florida, and that's a big reach for them. So that's a key aspect of care. Certainly these urgent care environments, the same thing. So the more we can build out into the community, I think the opportunities for the healthcare systems to integrate and to build these relationships. But I think it's more than just plopping down what looks good on a pro forma from a healthcare system's perspective in a neighborhood. We really need to go into the neighborhoods. We need to understand what the community needs are, how those expand beyond just the urgent care and emergent care environment, and what those communities really need. It goes back to some of the things that Rebecca was talking about. Opportunities for community spaces. What are some of the access issues in these various areas, and how do we take a deeper dive, and what healthcare systems are willing to take a deeper dive with us there, I think is an interesting perspective.
You're seeing uncommon partnerships starting to pop up where there's maybe more of an alliance with the school or with the library in the community to try to have better access to the patients.
To some extent, I think pediatrics, it really falls into one of two pretty distinct camps. It is our primary care, or it's a subspecialty care, and there's not a whole lot in between. Children either need to see a doctor because they have something that's happening to them right now, or they need to see a doctor because they have a condition that is potentially going to last quite some time, if not their entire lifetime. So it's a little bit more distinct than the adult care environment, but I do see opportunities there, especially in the schools and community resources like the libraries to ensure that we have good access to that primary care that's really important to a child's development, whether that's fetal care for a maternity patient or whether it's ongoing pediatric care.
Mm-hmm.
I think what I was going to say, Angela, was the one thing though that it's kind of the elephant in the room is, right now the caregivers, do we even have enough caregivers for all of these places, right? I mean, they're getting out of the field just as fast as they can.
Yeah.
We were facing healthcare shortages to caregiver shortages to start with, and it's just growing exponentially right now. So
yeah.
Yeah, so I love that you brought that point up, Anne, and I'm wondering if you're seeing any larger trends that maybe help people work more at top of license or provide maybe group care settings or other alternatives that might alleviate some of the pain with caregiver burnout and shortages.
Well, I'm one of the things we're seeing is several of our clients, and they're, even some of the rural, I'm sure rural is seeing it as well, is they're providing housing. So because housing's expensive. We do a lot of work up in the resort areas up here in Colorado, and people can't afford to work there. They're trying to attract people, and so they're actually paying for housing or subsidizing it greatly. And I know that occurs in the rural area as well. So it seems to be the big trend right now to just retain or attract providers.
Interesting. Rebecca, what larger kind of overarching trends are starting to move the needle in rural healthcare?
Just, I guess, sort of change maker in rural healthcare right now really has to do with the last year with our pandemic, and just how some of these very old, really outdated facilities that were just barely able to survive, if they're still there, what are they doing that's right, and what can they do that's better? I think that really pushed many over the edge when it comes to recruitment and retention of staff. I think for a long time, we've worked with our clients to, set up programs where they're reaching into the high schools and bringing students in to learn about healthcare and inspiring them to become nurses or CNAs or physicians, so they might provide a little workspace for them or have them do some of the things that they can inside of a healthcare setting. So that the idea that you're trying to recruit from within has always been something that I think rural facilities sort of had to do, and rural communities wanted to do, maybe as their only resource. But I would say that when you mix that on top of some pretty challenging economic situations and everything else that we talk about when it comes to rural healthcare, and then you put the pandemic on top of it, I really think that's just the biggest thing that people are trying to deal with right now. And how do we design our facilities so that they can manage another one or continue to manage now? Mm-hmm. These might not be very big places. It might be a 5,000 square foot clinic. So how do they have an in and out entry point? Where's their testing area? They're very, very small. So it's difficult. There's no doubt about it.
But I think the pandemic has made at least me acutely aware, as someone who lives in a major metropolitan area. I'm much more familiar with the numbers now of how the disparity between urban areas and rural areas and how that's affected people's outcome in the pandemic, that I have to hope that healthcare systems are looking beyond just the business case of operating these facilities and really understand what this means. It's clearly having an impact to outcomes and ultimately mortality rates across rural America.
I think that's interesting because the news is just so surrounding us these days, and yet almost all of our news that we want kind of wants to be localized for our unique situation, but we're taking in all this stuff. And when you said that, you're in Florida and the Southeast and Atlanta, rural there means something completely different than it means in the Midwest and the West. Mm-hmm. Where in the South, or maybe even along the Atlantic seaboard, rural might be, a 45-minute drive to a larger metro area. Whereas you go out west, it's nothing for that to be 2 to 4 hour drive.
Yeah.
And the context is wildly different, I think, especially where healthcare is concerned in an emergent situation. I think that was alluded to earlier today. And I noticed that we're talking about rural, but rural really means something different to each one of us.
Yeah.
Absolutely.
Where I live is considered rural, but other parts of the country would consider it completely suburban. And if I was, a Wyoming person might say I lived in the city. So, it's so different. I noticed along with that, information that we're getting, the American public has probably never been more educated, and I'm using that term loosely, on healthcare issues than ever before. But the question is it good education or not, and how that's possibly impacting their ambulatory choices as well. Has anybody seen any or had any client discussions looking at this kind of universally with this unique situation we find ourselves, where education or lack of education's come into play?
Well, I know I've talked to, we're not doing any work with them currently, but talked to a healthcare provider here in Georgia that operates 11 hospitals across the state, and they're in varying size cities, some here in Atlanta, some in much more rural areas. And they're trying to figure out how to ensure kind of a consistent experience across the system, and how the education of the community affects their ability to have access to healthcare in those environments, now that they're the sort of parent company behind a whole series of what were previously community hospitals.
So,
and Steve, can I add something to that? And I think the one thing that I feel I've learned over time when it comes to working with different communities is that every single one of them is completely unique. And when it comes to what makes sense for that place, you have to let them tell you that. You can't, just have an idea of what it means to, do something that has value in a community just because you read about it in a book or you studied it online. You really have to create the forum where people can tell you what it is that they want. And you have to be a listener and be able to integrate that into your discussions with providers and what it is that they want to try to do in any community, small or large.
I think that's really good advice, Rebecca, for those of us who find ourselves in design meetings with clients, users, staff, the community, and thinking through all those thoughts. As we move toward wrapping up our discussion today, I'm going to start with you, Rebecca. Last takeaways on how you see the future of ambulatory care within your practice, both the rural focused practice and your urban projects as well.
I appreciate what I've learned in working in the indigenous communities where I've had an opportunity to work. I really think when it comes to ambulatory care and comprehensive care, I think they are, many steps ahead of us when it comes to caring for the whole well-being of a patient. And I really appreciate that approach. I think that certainly, broadband is just something that I'll just go on and on about until we have it where everybody that needs it can get at it. And I hope that takes place with some of the new, stimulus approaches when it comes to our government funding and federal programs in order to make that happen. So I also see that trauma and fat is going to really resonate after the experience we've all had of 2020, and when you start to read about that, those design principles of trauma-informed care, I think that makes tons of sense for not only folks that we've been dealing with for a long time, but it's that whole integration of behavioral health and mental health aspects, as well as everything else we've talked about. So those are my takeaways. And of course, we could talk again about those mobile units, but I think those are a bit of our future as well.
Wow. No, that's great. And I really appreciate the reminder about your work with the indigenous communities.
That's great, Rebecca, and appreciate the reminder about your work within indigenous communities and how wisdom can be found in all sources and environments and truly everywhere, that it's not always the traditional top-down academic ideal of knowledge. How about you, Karen? Last takeaways on forthcoming changes from your unique pediatric design environment?
I'm really passionate about design for neurodiversity in pediatrics, and I see a huge hole here that we need to fill both in our inpatient and outpatient environments. I think that relationship to the community, which is something we've been talking about over the last hour, is incredibly important, whether in peds that's a teaching kitchen or a healthy lifestyles gym, or just opportunities to better inform patient families about how to successfully coexist with some of the diagnoses that their patients have received. I think those are two critical things. And then Anne brought it up at the very beginning of our meeting, but we've been talking about supporting the family as a whole in the outpatient environment. That's something we've been looking at on the inpatient environment for a long time, whether that's rooming in for our patients and their parents within the space. But I think in the outpatient environment, whether that's nap and respite rooms, resource spaces, community spaces, opportunities for family members to continue doing some work when their patient is being seen by the provider, those are all important parts of ensuring that everybody has good access to healthcare and that it's a resource that's used for the betterment of our society.
Wonderful points, Karen, with so much of that wrapped around the idea of compassion and empathy for patients who are our neighbors, being community citizens and part of the collective, and not just a number to be treated and processed, which is critical in times like this during dire circumstances. Finally, Anne, since I asked you to start several of the questions today, you now get the chance to end this one.
You know, as Karen had mentioned, respite for families, but we can't forget about the staff either, and respite spaces for the staff, just giving them space. Now nobody wants their workstations 4 feet apart anymore, right? So how are you handling that? How are you handling families like Karen mentioned as well? Flexibility, modularity, because whatever you do, it's going to probably change. And how are we adapting in the future? And just how are we getting the community to these buildings and feel comfortable? Again, talking about, do we have a gym? Do we have daycare? Just how can we make it so that it's not, I got to go to that place again, type thing. So, yeah, I mean, lots of changes coming, right?
We're going to be dealing with trust issues for a long time as architects for the medical profession. What's happening with COVID and vaccines has really challenged the trust of our medical system. And how do we address that? What can we do to make the community feel comfortable and want to come to a healthcare facility to seek help?
Mm-hmm.
I think that's another discussion that you and some of the college folks might want to have.
Thanks, Rebecca, for yet another really good point. So on behalf of Angela, myself, and those within the healthcare community who may be watching this at some future date, I'd like to thank the three of you for bringing us three very unique perspectives, yet with a lot of commonality of thought and experience and ideas for the future.
You to all three of you for being part of this initial relaunch of Master Series, and we look forward to continuing the discussion with you in the future as well as to future episodes.
Thanks for the invite.
For having us.
Thanks, everyone, and have a wonderful day.
Right.